Mustafa, thank you. Can you ask them to do the report, and may I request you to ask them to send the report here so that we can actually read and look what we need to write, especially in such cases where a lot would depend on what you've written. So you need to be very clear that you haven't clearly seen something so that decisions are not made based on what our reporting is. End of the day, people look at your report, they do that, and they'll say, the report said that. So it's very important that you clearly. The radiologists don't take any responsibility for any of the reporting. Please correlate clinically. हम लोग कहते हैं
Hello, can you hear me?
Ji, we are sorry. Ji, we are ready. Can you tell us about the patient?
Yes, sir. So the next patient is a 50-year-old male who has a complaint of abdominal pain and progressive jaundice for about 4 months. His CT scan showed enhancing soft tissue density seen in the pancreatic head, measuring 5.1 into 4.4 centimeter in AP and transverse diameters. CBD and intrahepatic ducts are moderately dilated due to the mass effect, and CBD measures 1.8 centimeter at that time. We put in a CBD stent. The mass was abutting and encircling the portal vein confluence around 180 degrees, and the fat planes between the mass and the portal vein were lost. So an EUS was done on 21st of March 2019, which showed a large hypoechoic heterogeneous wall circumscribed mass measuring 4.2 into 4.8 centimeter in the head of pancreas. Mass is very close to the SMV and portal confluence with the curia of abutment. Overall mass seems separate from the vessels. No peripancreatic lymph nodes were seen. Pancreas and pancreatic duct were normal at that time. CBD was dilated 1.4 centimeter with stent seen in place, which was patent. No obvious abnormality seen in liver, spleen, and kidney. Multiple passes of FNB were done. So the histopathology says the FNB report that there are atypical cells in the sample. So we have kept this patient for rebiopsy via EUS. Thank you.
Okay, so this is one example where our sample was not adequate according to the cytopathologist, although they saw atypical cells, but they did not have enough material. And despite using what we used, obviously there is no 100%. It also goes to show that we don't select our cases, you will, in my experience, I mean, and this is something that again, there is somebody who's looking at for the last 3 months haven't completed it, and the big negative in our unit here is that this is a surgical unit, not negative because of surgical unit, but because I don't have gastroenterology fellows. If I had GI fellows here, I have enough material to accommodate many of them for very nice projects. But obviously surgical fellows have their interest more in the surgical field. So when we have to dig out things, and everything is archived here, and that is very useful. So we don't exactly know what our yield is after the ROSE technique, but before that it was no more than 3 or 4 out of 10. I can tell you that. But it's close to 8 or 9 out of 10 now. Okay. And that's the difference. Now we have gone to FNB, but this is an example where we've done FNB and I thought we had good core, but the lab came back and said no. The other problem is that the cytopathology backup that these guys quote is totally different than the cytopathology backup we have and the support we have from the cytopathologists. The numbers are very small. They haven't had most have no experience of dealing with the sample that we are sending. We are sending almost all our samples to Shaukat Khan. Shaukat Khan, no. Well, Karachi, and then it goes to Lahore. And we have a direct. Yeah, we have a cytopathology.
Ready?
So I'll tell you why. Because we were developing a service. So we want to keep most things reliable, especially when you're early on. And secondly, really cytopathology is a field where
Good.
I mean, the volume we have,
बहुत अच्छा किया
the
है।
person, if we
it's
start doing all
जबरदस्त।
the cases that are referred, and I'm
वो
sure the same
ज़रा
applies
इस
to
मॉनिटर
you.
को मूव कर
I
दिया
need a
है, इसको
cytopathologist for
उसको
myself.
उधर रख दिया है,
I'll
जो
give
ये
them
है
enough
क्या
samples,
ज़्यादा
hopefully to
easily
cover
reach
their day
वाला।
here. You know, exactly the same way as it's done in Florida. लेकिन वो issue यही है कि you know time constraints and government setup.
यार ये ग्लव्स
ये cytopathologist ही नहीं है.
हाँ ये दूसरा ये नॉर्मल वाला दे दो।
I even
sterile
offered
नहीं चाहिए,
somebody, I
वैसे ही
said
दे दो।
मैं बात करके आया था फ्लोरिडा में, तो I spoke to Khalid, cytopathologist, उसका नाम भूल गया मैं, वो जो the lady that there was there.
So
She said, I said 6 months के लिए मैं भेज देता हूँ ना किसी को. यहाँ पे आके मैंने बोला कोई anybody interested, we'll arrange that.
आपके स्कोप चेक कर लिया, बलून चेक कर लिया आपने?
किसी ने कोई feedback
चेक करना है थोड़ा, और उससे सक्शन होगा नीचे वाले से।
मेरे हिसाब से तो अगर उस जैसी, but it's like actually,
Good. थोड़ा सा,
you know, if you're doing cases
देखिए ना,
with someone who's very good,
ऐसे रखना है
you do a
ताकि
few
एयर
months
इसमें
and
बिल्कुल ना हो। अब
obviously you
सक्शन
learn
करें
very
ऊपर वाला
quickly.
बटन,
उसी
all the
तरह
way, all the way।
cytopathologist was unbelievable. That there,
अब नीचे वाला इसको एक
and
दफा
that
फिर फिल
makes the
करें,
whole difference यार. You're
फिल करें, फिल करें, फिल करें।
big difference ना.
Okay,
I think it will take time,
ऊपर
inshallah
suction कर
हो
लें
जाएगा,
उसको।
but I'm sure it will
जब
still
आप
take a
full
few
suction,
years.
full suction, all the way, all the way, all the way suction step. Can you hear me?
Yes, we can.
So if you put a balloon on there, just for the candidates, एक मिनट ज़रा दिखा दें. So always check the balloon before you put the scope down. You just want to make sure that there is no air in there. So the way you fill up the balloon with water is the lower button on the EUS scope.
So the water button, the blue button, is the one that you use
press
for
all the way.
yeah, pressed all the way. So
Okay.
it has two functions.
Okay. So the upper one is when you press it all the way, what it does is it suctions the water out of the balloon.
Yeah, we saw that. Yeah.
If, however, if you press it halfway, that suctions the air out of the lumen or
Okay.
fluid or whatever you want.
Okay.
So this is very important. So halfway air and fluid from the lumen, full way water from the balloon. Okay.
Okay.
And the same thing is,
आप सबने EUS को,
and the other thing
I think
is,
it's very important to जी Khalid.
हाँ जी, the lower button has the same has two functions as well.
Yeah.
Well, if you just actually three functions. If you put just your tip on the button, that puts air in there.
Yes.
If you push it halfway, that would clean your lens. You can see the water going down.
Yeah.
And if you push it all the way, that would fill up the balloon. So these are the things you need to know, because once you are in the patient, you need to know if the lens is not working, how much, if the lens is not clean, how much button you need to press, and if you just want to fill up the balloon with water, how much button you need to press. So you please remember all those. The lower button has three functions, upper button has two functions. Gel लगा दो. चल ठीक है लगा हुआ. Okay. So here our objective, training objective is like do the stomach exam, GE junction exam, aorta, celiac, pancreatic body and tail, and ठीक है, okay. So this is just like जैसे आप the way you do the ERCP, and just want to make sure.
On 30 we put this and big will on up.
For what? I'm sorry,
see,
not
just
not
to
too
see
much.
that.
You don't want to see the whole lumen, obviously. You just want to slide by, okay? Because if you see trying to see the whole lumen, your scope is going to be like this, okay? So you want your scope straight. So you have to see a little bit of lumen. You can see the little bit of lumen. You can see the wall, but you don't want to see the whole of it, okay? Then you are moving it down like this, okay? Okay. So let's get to the G junction, okay? And just relax, just going to be very relaxed. We're going to keep a scope in neutral position. That hand goes that way, and we are almost there, okay? Okay, you see that G junction? So let's get suction that fluid because patient is not intubated. So how was the suction? Halfway, not the full way, right? Okay. halfway upper buttock. आप पूरा मेरा ख्याल फुल कर रहे हो.
नहीं मैं गया नहीं वहाँ आगे. वो है.
That's good, I think. Let's inflate now. Okay. Suction करें उसको. Suction again. I don't hear it. आ रहा है? अच्छा, अब आ रहा है. I think mucosa, you're suctioning the mucosa. That's why, you see that? Okay, so just no, don't need to push, okay? It will come to you if you are in the lumen. So just gently suction. A barbar mucosa suction karenge. Okay, if no, what I'm trying to tell, you see that was the second part where you said. So what I'm trying to say is, like, if you are right in the ear area, lumen, now suction. You see that how it comes to you. You don't have to go to it, okay? So from here, let's get back to the G junction now. Scope stays in the neutral position, okay? So right there, we're at the esophagus. You see the G junction right there, okay? So once you get into the stomach, rotate the scope a little bit downwards. You see that? You see the opposite wall of the stomach, okay? Not your body, just the scope, okay? So your body needs to stay straight. Go to the opposite wall of the stomach, big wheel towards you a little bit, and suction, 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 suction. Rotate the scope a little bit to the right. We're trying to get to the liver right there, okay? Rotate the scope to the right. You see that that's beautiful, right at the liver, okay? So from here, now you see most of the liver is to the right side, right? A portion of it is to the left side. So big wheel towards you. Pull the scope back. No, not too much. It's a small movements, okay? Small movements just to approximate and straighten the organ, whatever you are trying to examine, okay? We're going to pull the scope back a little bit, okay? Now the goal is for that 2/3 of the liver should go to the left of the screen, 1/3 should stay to the right of the screen. So thoda sa isko rotate kare, right there. You see that? How it's coming up now? Okay, we're going to pull the scope back a little bit. No, keep the big wheel towards you, little bit. Don't let the liver go away, okay? Okay, from here, big wheel towards you a little bit, please. A little bit big wheel towards you, further, 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 further. So let's rotate all the way to from 180 degree to 90 degree, okay? Keep going, 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 keep going. So right there is the aorta. So you see like how you came from one place to the other place. Let's see the aorta again. Okay. Did we miss it? Right. Okay. So now try to stabilize the scope, okay? Right here. एक मिनट ठहरिए ना, बहुत ज़्यादा आप कर रहे हैं. Just a gentle movements, okay? You do a little bit and it's going to do a lot. So release the wheel a little bit. Release the wheel means the wheel needs to go away a little bit. It's a very small movements. आप बहुत ज़्यादा कर रहे हैं फिर, ठीक है? So here, that's the aorta, right? ठीक है? And right now, I'm gonna freeze it here. Okay. So what structures do you see here? You see the aorta right here, okay? And what is that?
This is maybe celiac button.
No.
बटन उठा
Button लगा. Okay. So that's the crust of the diaphragm, okay? Because this is the celiac right here. Okay. So the crust of the diaphragm right there, the celiac right here. Okay. So I'm gonna unfreeze now. You have lost all that.
So the crust is, seems to be more of like a vessel.
It does not look like a vessel. I don't know. It looks like a solid organ. Okay. So it's gonna be a black. Okay. So big wheel towards. No. You have to maintain that. तो आप एक दफा दोबारा करें ना इसको maintain. Okay. इसको इस जगह रखना है आपने, ठीक है? आपको नजर आ रहा है ना इस जगह, ठीक है? तो I think what I'm gonna do is I'm gonna go ahead and go to the head of the pancreas, do the FNA.
Okay.
And then we're going to work on this. एक मिनट मुझे दे दो.
Zabardast.
Because I think we need to get the objective taken care of, and then we'll spend the time.
So the objective here, Khalid, was to go into the stomach, identify aorta and celiac artery, and just go to the pancreas and look at.
Yes, we
That
will
was
do
your
that.
intent.
We will do that in a little bit. But right now, I think what I need to do is I need to get the FNA of the mass. But before, you see the mass right here clearly,
Yes, we
right?
do.
Yeah. So
Yeah.
before I do that, मुझे यार needle दे देना 22 FNB needle दे देना ठीक. हाँ.
Ji Khalid, what were you saying?
I'm gonna just want to show you something. ठीक है मरीज. So I want to show you this here. Do you see the pancreas right here?
Yes, we do.
Okay. What do you see in the pancreas? And that might give you a diagnosis, like that might make you think that what type of tumor or mass that is, what sort of pathology. Okay. So here, do you see the splenic artery?
Yes.
You see the splenic vein.
Yes.
You see the pancreas, right?
Yeah.
And you see a duct right in the center. It's a very small duct.
It's very small though.
Okay, what does that tell you? There is a mass in the head of the pancreas. You have a small duct in the body of the pancreas. For me, if I see this and there's a mass in the head of the pancreas, I'm not thinking about adenocarcinoma, okay? Because adenocarcinoma usually causes atrophy and ductal dilation into the distal pancreas, okay? However, a neuroendocrine tumor, which also can cause the same, but sometimes it may not. But the lesion which really does not cause a post-obstructive dilation are either lymphoma or it does not look like an autoimmune pancreatitis, but that can sometimes appear like a very bulky head of the pancreas and you see a very small duct. So here, what I'm trying, and right now, what I'm thinking in my head, there is a mass there. I saw that the distal pancreas, there's no ductal dilation, no really atrophy. Number one is make sure it's not a primary pancreatic lymphoma, and number two is not a neuroendocrine.
Okay, Khalid, how often and how
You look at that rest of the pancreas, really doesn't look that bad. You see that it's a Pakistani pancreas.
How sensitive and how strong are you in what you're saying, and how often are you likely to be right in with what you just said?
So how often? That's a good question. I think
Most of the time.
probably yes. Most of the time, we'll find out in a little bit how wrong I am. Yeah, it's a little bit dilated here, but not too much. But this does not look like a pancreas to me of adenocarcinoma for what I'm used to seeing. I can tell you that. And that mass,
The mass does not
look like adenocarcinoma either. Yeah, so I think most of the time, if you see that, you're not going to find you're going to most likely find a, and here.
So there, if this was in this.
दे दो FNB. मेरे पे एतबार नहीं? अच्छा.
नहीं, उसको मैंने सिखाया किसी पे एतबार नहीं करना.
सही आपने सही सिखाया. So whenever you put the needle on there, you see that I'm putting a needle on there. I'm releasing the wheel, especially a big wheel, moving away from me, especially when I'm in the duodenum, because the scope is in long position. You pull the wheel towards you, that makes the scope even more stiffer. You're going to have a hard time pushing that needle through. So release the wheel a little bit, and then what it would do is like it will easily go onto that channel, and you can screw that. One thing is, whenever you have the needle, you see these two lockers. One is for the needle, other is for the sheath. So when before I put that, I'm going to move those towards me. So now they are facing me. When they face me, I put that on there, and then rotate it. When I rotate it, it's going to go around, and these are in the right direction, so I can control that. So if they are on this side, that's a problem. So first, before you start, make those wheels or locks facing towards you, and it really will take 75% of the turn, and they will be on your right side, and you can easily maneuver those. One other important thing which you need to keep an eye on, that this one usually comes fixed at 1, so try not to have to touch this. Once you open this, the sheath, you always have to adjust that before you can take the needle out. So try to, sometimes you will have to adjust the sheath, but try to keep that locked the way it comes. If you open it once, then make sure that you lock it really tight, because you don't, when you do FNA and you make up a stab with the needle, you don't want the sheath to be stabbing the duodenal wall, okay? So right now I'm in the duodenal bulb. We see that mass there. We see it's a quite large mass actually.
खालिद खालिद
जी
मैं ये बोल रहा हूँ कि इसमें एक चीज़ मैं ऐड कर दूँ आपके जो आपने अभी बताया, ये शीथ का जो मामला है, if your needle is not coming out,
yes,
and
so,
somebody has manipulated it, don't try and use force. The
oh,
needle
yeah,
should always come very smoothly, and you should see the needle coming out without resistance. Otherwise, you'll puncture your scope.
And here you can see a central necrosis in this one. Here there is a necrosis here, there's a necrosis here. So you really, the viable cells are going to be on the side of a large tumor. So your goal should be go towards the periphery right here. And the larger masses, actually it's harder to fan those as compared to the smaller masses. So what we're going to do is, it's going to be hard to take out needle into this place. I can go into the D2 and try that for another area, but our goal is going to be stay on this periphery, because the needle will come out of here, and this is going to be likely trajectory of the needle. So here I can put a Doppler, make sure there's no major vessels. So this is a neuroendocrine tumor, by the way, just by looking at it, okay? And the reason I'm saying is I see a lot of vascularity in that, and neuroendocrine tumors are vascular like that. And I have seen a primary pancreatic cysts too, and those look like that.
So when I
well.
saw this, I thought if it was in the stomach, I would have labeled it as gist.
Yeah. So
but the other, we thought that this is not straightforward adeno-CA for sure. I was hoping that I would get net, but unfortunately we got some atypical cells, and that's all.
So yeah,
I'm sure we'll get.
I hope we will get some good tissue here. Before you puncture it, you gotta make sure that this is you put a little bit pressure on the scope, and it's nicely approximated. What I do is I usually use my big belly and hold the scope here so it doesn't fall back. If it's still it doesn't help me, I will ask the tech to hold it for me and don't let the scope come out.
Your honesty has not stopped impressing me, Khalid.
Yes. About big belly. So here, right now, I'm holding the scope there. You see the needle tip there, right? You can see the needle.
Yes, we can see the needle tip.
So here, I say that when you take the needle into the lesion, I call it that you have to have a controlled, safe, controlled stab. That's how you do that. So some people, what they do is they lock this locker in the middle of somewhere like at 4 or 5 centimeters, so their needle doesn't move beyond that. I don't do that because I don't think I have a control over that. So what I do is I put my finger here, right there, this finger above the locker, and when I do this, this is the finger which is stopping from the needle going too much into deep there, okay? But once you get a practice of that, you can really get a real good control of that. Here, इसको पकड़ लो मेरा भाई. इसको इधर थोड़ा सा press करके रखना, ठीक है? And you're going to see that I'm going to do a quick stab. You see that? How that went in there? It's a really quick controlled stab. That's the whole purpose of this.
Okay.
So here I will go in. We need to take this out, style it. And I'll talk about the stylet later, but I usually use the stylet only in first pass because the needle comes with the stylet, so it's already straight, so I don't need to take that out first. But once I go in, I take the stylet out completely. And for the other passes, I don't use the stylet. It's been proven that you can do without stylet. So 1, 2, and sometimes really you can feel that that little bit crackly stuff coming in there to that and into the needle. So I'm gonna just make one more, so that would make it total 4, and then we'll take it out.
Do you need suction along with this?
We'll talk about that later. But for any solid mass, I prefer not to have to use any sort of suction, and unless I'm not getting any tissue.
So someone once taught me that if your FNA is dry, okay, especially in a node or hard mass, then if you don't get anything, then you apply suction, but you don't use suction from the very beginning. Make a couple of passes and then switch on to suction, switch the suction on, do some more passes, then switch the suction off, then do a few more needle jabs, and then come out. Would you agree with that, Khalid?
Yes. I like solid, I hardly ever use the suction unless really I'm not getting anything there. And I still will do 2 passes without suction, even if the first pass doesn't show anything major. Then what I'll do for the second pass, I will do that without suction still, and if I did not get any tissue with the second pass, then what I'll do is I'll do use the suction for the third pass.
That is 1 in 1,000, Khalid.
My method of suction is totally different, by the way. I do not use the suction the way everybody else does. I use what I call an intermittent suction. This is my own way of doing it, and I'm not imposing that on anybody. What I do is I do get the needle, go, if it's a FNA needle, let's suppose, I do 3 or 4 without suction, I turn the suction on. I do 3 or 4 back and forth, I turn the suction off. And then I do it again same way. I do the first jabbing and the last jabbing without suction. My theory behind that is, so when I do the first one, I don't want the blood to come into the needle. So once the tissue comes, after that, it's going to be mixed blood and tissue. But the last one, I do not want to do with suction, because that tissue, I want the real tissue if possible, because when you take the needle out, you put the specimen on the slide, or you put a stylet through the needle, the first thing which is going to come out of that needle is the last thing which went into the needle, and I want that without blood. So that's my way of doing it. And I call it an intermittent suction. I have not proven that that's better than the other, because there are many studies, suction, no suction. We have proven that suction is not really needed most of the time. And some other studies, they show that suction is needed to get a better specimen. So that's what I do. Any comments, Saad bhai? Needle le aao bhai. Okay. And other thing was like with this needle, you saw that I only really went back and forth 4 times. So FNA needle, you go in one place 4 times, and then you try to fan in different areas. With FNB needle, I feel like I think you just need to go in one place only once, because it's a cutting needle. It's taking the tissue into the needle. You are just making just a path there, and digging a tunnel in there. If you go there again, it's going to be all blood.
You understood that?
Okay. कैसा
everybody?
टिश्यू था और कितना था काफ़ी था सो मुझे बताया जा रहा है कि काफ़ी टिश्यू था सो we're gonna make more pass लेकिन स्टाइलिस्ट की जरूरत नहीं है हाँ टिश्यू काफ़ी सारे हैं काफ़ी था ना So I've been told like there's a lot of tissue there, so we'll make one more pass. And one thing I really want to take a look at the slide and see if we need to send for tissue amount is good. So I need to take a look at slide, and I feel like we should send one for flow as well, flow cytometry. So I will make total of 3 passes. Next pass, I think we can put all in cytolite, and the one after that we'll put in a flow.
Have you told Wasim that you need to put it in the...
And I'll,
Wasim वहाँ है?
जी हैं.
Okay, fine. So he'll take care of.
Okay. ये जरा होल्ड करो स्कोप को मेरा भाई. One. And you can see that the needle, the path it makes through the lesion. 2, you can see that. And I'll change the trajectory a little bit.
Do you come out and change the trajectory
Right at
for
the,
a large mass?
Yeah, I don't come out of the lesion. I just come to the edge of it. Wasim, क्या कह रहा था? Wasim bhai. Wasim.
So like you said, Khalid, sometimes I mean fanning in the large masses is difficult.
So I think we have a lot of specimen on the first one. So what we'll do is that is enough for even cytolite, touch prep, everything.
Has
so
he put it in cytolite?
He did. And he's gonna put this in flow. Flow में डालना है. Flow में भी डाल दिया. और वो कह रहा है बहुत सारा था पहले में तो
इसको बोले इसको भी डाल दे उसी में.
हाँ, ये भी सारा मिक्स कर दो फिर कुछ फ्लो में डाल दो कुछ साइटोलाइट में डाल दो ठीक है.
Possible showing a sample?
वो सैंपल जरा दिखा देना
अगर है उसमें तो.
हाँ इसमें ये डाल के तो उसमें दिखा देना. Is Farooq still there?
Farooq is not here, but Mustafa is here.
और न मुस्तफ़ा शरीफ आदमी है. फारूक किधर है?
जो शरीफ आदमी है वो यहाँ बैठा है और जो शरीफ नहीं होगा वो कहीं और होगा.
हाँ यही ना. उसको मैंने ये बताना था कि कैसे करते हैं. क्या?
So you can see the stent very nicely.
Here, that's what I was gonna show. You just stole my thought right there. You see the stent coming out of that. This looks like I mean, honestly, just by looking at it, either it's a neuroendocrine or a lymphoma. It's not adenocarcinoma. And even if you look at the overall echogenicity of this lesion, it's more.
Mustafa is saying this could be cystic degeneration within the neuroendocrine tumor.
No, that's what I'm saying. This is a cystic degeneration. This is a necrotic area. So what I was going to say something else actually. What I wanted to show you that is this is not a hypoechoic area mostly. It's a lot of area in that is isoechogenic, and that's a feature of a neuroendocrine tumor. It is a neuroendocrine gas, I said. So I think we got that taken care of. What I'm going to do is here and
there were some lymph nodes there adjacent to the
yeah, it is, but I'm not worried about that. There are 2 lymph nodes there.
Yeah.
Okay. So what we'll do is here you can see that it's really coming close to the portal vein. You see that? Yeah. And I don't see I don't see an invasion. But I also don't see a fat pad or fat plane between the mass and the portal vein. You see, it's there's a good plane up to here. Let me show you that a little bit better. So you see a nice fat plane right up all the way up to here, and then that even though it's not an invasion, but you lose that plane, so it's involving at least the wall and it's going down into that.
Would you say this is abetting?
At least abutting.
So that's what I wrote in the report. So
You were right. Absolutely.
I'm glad you agree.
Yeah, it is abutting. But here, when I go a little bit to the side, I'm losing the portal vein. But I think that's the way the image is, and it's a kind of a little bit cross-sectional image. A tangential image, sorry, not the cross-sectional. So here, yeah, I think it's just a tangential image. What we're gonna do, now I'm gonna come back, we achieved what we need to do here, so I'm gonna work with the trainee and we're gonna work on the stomach. So I just wanted to make sure that we get the job taken care of, get the job done, and then we can work on the training part, okay? Any questions right now? So, वापस आइए. Good. Keep coming back.
Khalid, we are done. Thank you very much.
Okay.
So, is there anything? Is the next room ready?
So I'm gonna just keep working here, and we're gonna do a couple of times this.
Can we go to the next room, please?
Okay. Suction कर लें इसको. Okay. ठीक है.
अब हम क्या करें?
तो स्कोप को स्ट्रेट बिल्कुल ठीक किया आपने.
Okay. Now we also need to plan. Farooq, we are with you.
ठीक है. थोड़ा सा इधर से भी रोटेट करें.
So if you want to just share the report, Mustafa. So was that esophageal mass? What you described was OGD finding, esophageal mass.
You see?
Hello. Can you hear me, guys? Hello.
See you.
Hello.
हाँ जी फारूक आवाज़ आई है?
जी मुझे आ रही है. आपको मेरी आ रही है आवाज़?
हाँ जी ज़रा कम है, माइक अपने नज़दीक कर लें.
माइक क्लोज कर दें प्लीज.
बस ठीक है, अब ठीक है.
Can you hear me now?
Yes, very clear.
Acha, thanks for coming. I really won't take long for you guys. I was asked to do this lady that you guys did a couple of days ago on the ERCP course, as you had seen a distal CBD stricture on the ERCP. CT में उन्होंने ये बताया है कि या ये ampullary mass हो सकता है या pancreatic. They're not quite sure. I really just wanted to show you a couple of things यहाँ पे. So for the trainees in the audience, this is D2. We've got the bend on the scope, and as you can see, this is the aorta I am seeing. We've talked about this yesterday. अगर आप लोग मेरा हाथ दे सकते हो, so literally 5.
नहीं, we cannot see you क्योंकि
Okay, okay.
कमरा कुछ ज़्यादा
कर दीजिए, ऑन कर दें जी, मेरी लाइट ऑन कर दें प्लीज. एक ऑन कर दीजिए. Okay, can you
Now
see?
we can see you very
So what we said, we go anti-clockwise, so we should see IVC. Sorry, let me just take the air away. Can you guys see that?
well. Yes, we can see that.
Okay, let me just, there it is. And as we go clockwise, aorta, now all I'm doing is going slightly more clockwise, and I'm getting to the pancreatic tissue. जो मैं आप लोगों को दिखाना चाहता हूँ वही, this is the ampullary mass, which I'll freeze, and you guys should be able to see ever so slightly more as I come back to it. And I wanted to show you that I think there's a duodenal wall involvement, so we won't be able to do ampullectomy. Had you thought? इसको freeze करें picture को please, right? Okay. So if there's my cursor there. So this is the mass. Can everyone see that in the audience? This is or if you see, this is the duodenal wall muscularis. Is that visible in the audience?
Yes.
Right, okay. So my feeling is कि इसको unfreeze करें. I think there is actually involvement of the muscularis. So therefore, you can only do surgery for this lady, not an endoscopic. So this is one of the ways that we ask or get assessed the ampullary lesions, whether they are surgically resected or can we possibly do an ampullectomy, and this is how we assess that. And I think there is, so if you just freeze there for me, freeze there please. Freeze kar dein please.
Yes.
Okay. So there, at this point you can see that there is no clear demarcation of the muscularis within the mass, and my feeling is that this is where it's actually going through the duodenal wall. So therefore we cannot do the ampulectomy, and if endoscopic ampulectomy, so if we need to, we probably will have to do the surgical resection. This is all just I wanted to see really. You can go to the next station. I'll carry on doing the FNA for this.
Okay, thank you.
उतार दे, mic
Thank you,
उतार।
Farooq. Any question?
To come back again. तो अभी मैं D1 में हूँ. मैंने आप, can you hear me in the audience? Hello, audience, can you hear me?
Yes, we can hear you.
Thank you. So D1, I'm right at the bulb. Where is it cursor? Bile duct, portal vein, pancreatic duct. What I now need to show you, at this point, trainees के लिए, all you have to do is you go slightly left, तो आप hilum में जा रहे हो. I should expect to see a cystic duct coming at this point as I head towards the hilum. मैंने right hand से कुछ नहीं किया है. All I'm doing is my left hand is going there and I'm seeing the hilum. Okay, we're still, and you've got liver right under the portal vein. I can't see the cystic duct properly, but let me just and the other thing is I'm still staying, oh there it is. That's the cystic duct that comes just above there, right? So bile duct is there, that's your cystic duct. अच्छा अब सिर्फ आप लोगों ने bile duct को focus करना है, and all I'm doing is this, and you will see this bile duct is going into that, as it goes into the ampulla, we should start to see that mass there. Are you guys happy? I haven't even touched my right hand, guys. This is the ampullary mass.
Farooq,
GG.
CPD wall is thickened, isn't it?
Yes, so I think this is uniformly thickened probably because of the obstruction and the ascending cholangitis. But you're absolutely right, it's a double wall structure. Why I don't think this is malignant thickening? Because agar aap dekho na, let's take trainees right at the top. So abhi hum aa gaye bilkul hilum mein. Yes, you can see nodes there. These are hilar nodes. This is uniformly thickening, which you can actually measure from here to here, the uniform thickness of the bile duct all across. This you can see sometimes in autoimmune cholangiopathy, ischemic cholangiopathy, or inflammatory ascending cholangitis can sometimes look. At this point, we really can't see the stent जो आप लोगों ने डाले हैं कल. But as I just start to go down, the stent comes into the picture, and at this point you are walking and you start to see this ampullary mass as I walk in. So pancreatic duct and the ducts walk into this mass, and this is what we're going to take the biopsies. You can still see the bile duct, there's a stent there, and that's where this mass is. And so this is the duodenal mass. As you can see, the stent is coming through, and we are into the duodenal wall, and this is the ampullary mass.
So basically there is wall stratification of CBD and cystic duct as well, because mucosal lining is intact and we can appreciate submucosal edema.
That's
giving
right.
a stratification
Very true,
of the
very
wall,
true.
Right. Okay, thank you.
Very true. Thanks guys, you don't have to hold on to me, you can go to the next station. Thank you. ये माइक बंद कर दो प्लीज, और अब इनकी वापसीज कर देते हैं.
Where the celiac is, celiac का रहा है, ठीक है, right there, ठीक है ना. हाँ, so let's follow the celiac नजर आई ना आपको वहाँ पे, ठीक है. celiac थोड़ा सा release करें wheel को. Release करें means big wheel away from you. I don't see the big wheel away from you. Gentle. Okay, ठीक है. What that does is that takes you straight to the pancreas. ये देख रहे हैं, pancreas आ गया, ठीक है. अब duct right में इधर है. अब यहाँ से rotate करें right की तरफ.
चार एम्पल
पूरे हो गए. हम okay. नहीं और खोलने की जरूरत नहीं है, आप इसी पे खत्म कर लेंगे, ठीक है. नहीं हमें भाई जब लिवर है, मास्क में आप कैसे पहुंच गए? मास्क का तो आप you have a lot of air in there. This is all air, ठीक है, and this is liver. You are staying away from the wall, so that's why it's so far away from you. So you need to move the big wheel towards you. अब ठीक किया आपने, okay? Not too much. तो आप ना बहुत ज़्यादा कर रहे हो movements इसकी wheels की और हर चीज़ की. It's a very calculated, small, gentle movements. ठीक है?
अच्छा इस मूवमेंट से पेंक्रियाज नहीं आएगा. If you want to see pancreas.
बहुत सारी movements से pancreas आएगा, लेकिन आपको एक systematic करना पड़ेगा, ठीक है? मैं अगर इस पे करूँगा तो मैं pancreas को मैं सीधे pancreas पे चला जाऊँगा. But that's not how you learn. ठीक है? The learning is going to be you have to get to the aorta, the celiac axis, big wheel towards you a little bit towards you, ठीक है? और इसको rotate करें, scope को बिल्कुल gentle रखें, ठीक है? आप आगे. थोड़ा सा राइट देयर, ठीक है ना। हाँ, तो यहाँ से अब थोड़ा सा इसको जेंटली एडवांस करें। नहीं एडवांस करना है, स्कोप को एडवांस करना है, ठीक है। और स्कोप को करीब से थोड़ा सा पकड़ने जब आपने एडवांस करना है तो। अभी तो मैं रिपोर्ट देखूंगा ना।
रिपोर्ट तो वही सेम है जो आपने दी।
अच्छा सही
ये
है,
बताया आपने
मैंने देख लिया ना वो पैंक्रियास को बॉडी को देख के आपको पता लग जाता है कि मास कौन सा
आपने
है।
ये देखे से
नहीं मैंने अभी नहीं देखा।
I'm not sure that what you showed me as net rate is what I'm seeing here.
नहीं स्मॉल सेल्स है ना सारे।
Cells are small but
नहीं मैंने देखा नहीं, मैं देख लेता हूँ अभी।
very good adequate cells and excellent
स्पेसिमेन,
specimen slides also excellent specimen slides everything.
ठीक है मैं देख रहा हूँ एक मिनट। उसको लेके नहीं जाना, उसको इधर ही है ना स्लाइड।
मैंने एक और चीज़
गुड, दिस इज हाउ यू डू। हाँ जी बिल्कुल जी बिल्कुल 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 ठीक है। आपको जाना चाहिए तो आल टेक ओवर। फुल ठीक है, ठीक है ठीक है। हाँ तो
This is the CV.
no understood, yeah, no I have not told anybody either. ठीक है, दोबारा एओर्टा को लेके आए। राइट देयर, गुड, गो बैक अ लिटिल बिट क्योंकि आपका मिस हो गया था। चलिए एक बार और करें। ये स्क्रीन नज़र आ रही है आपको, ठीक है ना। तो
The aorta will come after spleen.
नो स्प्लीन, यू आर इन द रॉन्ग प्लेन, नाउ यू आर इन द राइट प्लेन, ठीक है। ये हाँ इसको फॉलो करें, मीन्स के अब देखें ना उस तरफ जा रही है तो दैट मीन्स कि आपको व्हील थोड़ा रिलीज करना पड़ेगा और स्कोप को पुश करना पड़ेगा, ठीक है। राइट देयर टेक्स यू स्ट्रेट टू द पैंक्रियास, ठीक है ना। गुड, तो यहाँ से रोटेट करें राइट की तरफ। ये एक मिनट, ये दिस ब्यूटीफुल राइट हियर। थोड़ा सा वापस की तरफ जाएं। ये देख रहे हैं पोर्टल कॉन्फ्लुएंस नज़र आ रहा है आपको, ठीक है। mass is on the other side, you see that, that's the head of the pancreas mass. It's a beautiful view right here. So splenic vein, SMV, getting together, making a portal vein which is going into the liver right here. एक मिनट, ये आपको नज़र आ रही है यहाँ पे bile duct का stent right there, ठीक है। bile duct is right underneath, ठीक है। तो लेकिन let's pay attention to the pancreas, this nice, very nice image right here. इसको रोटेट करें राइट की तरफ, रिलीज करें व्हील को थोड़ा सा, गुड, एक्सेलेंट। थोड़ा सा और रिलीज करें, बिग व्हील अवे फ्रॉम यू। वी नीड टू ब्रिंग दिस डक राइट अंडरनीथ द ट्रांसड्यूसर, ठीक है। चलते जाएं राइट की तरफ, राइट की तरफ, बिग व्हील टूवर्ड्स यू अ लिटिल बिट, बिग व्हील टूवर्ड्स यू, बिग व्हील टूवर्ड्स यू। ये देख रहे हैं कैसे नाइसली ब्यूटीफुल डक्ट ऑल द वे टू द टेल ऑफ द पैंक्रियास। अब यहाँ से ऑपोजिट करें मूवमेंट, लेफ्ट की तरफ, ज़बरदस्त। थोड़ा सा रिलीज करें व्हील को। देखें कि मेन गोल के मूवमेंट्स कितनी स्लो मूवमेंट्स हैं, ठीक है ना। और दूसरा ये कि स्कोप को अगर आप ज़्यादा स्टिफ करेंगे तो प्रॉब्लम होगी।
This is splenic artery in vein.
ये लुक्स लाइक या स्प्लेनिक आर्टरी, ये स्प्लेनिक आर्टरी, ये स्प्लेनिक वेन और ये डक्ट, ठीक है, गुड। और साथ साथ ना सक्शन भी रखें, क्योंकि अगर आपकी एयर चली जाएगी ना तो दैट्स व्हाट वुड हैपन। यू देखा आपने सक्शन किया है तो आपका पैंक्रियास पूरा आ गया, ठीक है। एयर इज एनिमी ऑफ अल्ट्रासाउंड, ठीक है। चलो गुड, एक्सेलेंट। निकाल लें आप उसको न्यूट्रल करके सारा कुछ, ठीक है, गुड जॉब। थकी है सही गल है, कुछ खुआया पिया करो ना उन्हें, गुड जॉब।